Hello everyone, I'm Dr. Rachna Shanbhag Mohite, specializing in pediatric immunology, and today we shall be discussing about a young boy with recurrent infections. So let us start with a case. A 4-year-old boy presented with the chief complaints of fever for 6 days, cough for 5 days, and difficulty in breathing for 2 days. This was his chest X-ray on examination. We found that this boy was suffering from bronchopneumonia. When we took a detailed past history, we found that this boy was suffering from recurrent infections from childhood. At 18 months of age, he had bilateral otitis media. At 2 years, he had diarrhea. Between 2.5 years to 3.5 years of age, he had 2 episodes of pneumonia requiring hospitalization for 8 to 10 days and treatment with IV antibiotics and oxygen therapy. We often come across such children who come to our OPD with recurrent infections. When we have a boy with recurrent pneumonia, often the differential diagnosis that we think of is congenital heart disease. However, the echo in this child was normal. Congenital lung abnormality is another possibility, and a CT chest was performed. However, it was again normal. Cystic fibrosis can also present with recurrent pneumonia, but the sweat chloride test in this child was normal. And GERD, a nuclear scan was performed, and that was also normal. Since children with HIV can also present with recurrent infections, a rapid HIV test was performed, and that was non-reactive in this child. So this child had now come to us with recurrent infections and another episode of pneumonia. When we looked at his family history, we saw that he had a very significant family history. That is, he had lost 2 male siblings at a very young age due to recurrent infections. Also on his maternal side, there was history of death of maternal uncles at young age due to recurrent infections. So the working diagnosis in this child was a boy with recurrent pneumonia, past history of repeated infections, and a family history suggestive of X-linked inheritance. When we performed investigations, we saw that on complete blood counts, we could not get a clue to the diagnosis. This child only had neutrophilic leukocytosis. When we performed an immunoglobulin profile, we saw that IgG, IgA, and IgM, all the levels were low. That is, this boy was having hypogammaglobulinemia. When we performed a lymphocyte subset analysis in this boy to look at the T cell, B cell, and NK cell counts, we found that this boy was having absent B cells. So we have a 4-year-old boy with recurrent pneumonia, low immunoglobulin levels, and absent B cells. The diagnosis was very clear. That is, it was X-linked Agammaglobulinemia. And when we performed a genetic test, we found a mutation in BTK gene, which confirmed the diagnosis. So what is the message that we should take from this case? That a boy presenting with recurrent pneumonia, sinopulmonary infections, we must order a serum immunoglobulin profile. And if the serum immunoglobulin levels are low and the B cells are absent, we must think of X-linked Agammaglobulinemia. So what is X-linked Agammaglobulinemia? Dr. Ogden Bruton was the first who defined X-linked Agammaglobulinemia in a young boy who was suffering from recurrent infection and was found to have absent immunoglobulins. Hence, it was known as Bruton's Agammaglobulinemia. Later, it was found that this disease is X-linked in inheritance, and that is why only boys are affected. These boys present with recurrent pneumonia, otitis media, diarrhea, skin infections, and on examination, we often find absent tonsils in these boys. We know that B cells produce immunoglobulins in our body. But where do these B cells come from? We know that bone marrow has stem cells which produces B cells. These B cells then form plasma cells from which we get the immunoglobulins. However, in X-linked Agammaglobulinemia, the defect is in production of B cells. That is why these children have absent B cells and hence low immunoglobulin levels. And the mutation is in the BTK gene. What is the treatment in these children? These children need to be treated with monthly IVIG infusions. That is, we need to replace the immunoglobulin levels in these children. So the take-home messages are recurrent sinopulmonary infections. We must think of a B cell defect. A young boy presenting to you with sinopulmonary infections, always think of X-linked Agammaglobulinemia and order an immunoglobulin profile. As we saw from this case, a simple test like immunoglobulin profile can help you clinch the diagnosis. However, when we interpret the immunoglobulin levels, we must be very careful to look at the age-specific norms. And the treatment in these children is monthly IVIG and antibiotic prophylaxis. Hope this video was helpful. And to know more about other immune deficiencies, do check out the video on my channel. Thank you.